This is Chapter 24, Trauma Overview lecture. I wished it wasn't a lecture. I really would love to be able to have an interactive discussion with you, but it just doesn't work that way. Things going on the way they are, so sorry. Okay, the National Education Standards of Competency is what a competent EMT should be able to accomplish. And so in the trauma section of that standard, it says that you should be able to apply fundamental knowledge to provide basic emergency care and transport based on the assessment findings for an acutely injured patient. So we're going to be talking about the trauma overview, talking about the pathophysiology, assessment, and management of the trauma patient. We're going to do this by first of all talking about the mechanism of injury. We've talked about that a little bit in the past, but we'll continue to talk a little bit more about it. The trauma scoring system, rapid transport and destination issues, and those can be varied, and then transport modes. We'll talk a little bit more about transport decisions in another chapter, but this will be talking about different methods of transportation that we'll be covering. I'm going to go on and talk a little bit about multi-system trauma, recognizing and management of those multi-systems trauma. We're going to also talk about the pathophysiology, assessment, and management of those multi-system traumas, and then we'll talk a little bit about blast injury. I had a student a couple years ago in my advanced EMT class who got hired on with Spanish Fork, and she was so disappointed after first week working there. She said that they didn't get any trauma calls. It was just all just boring medical calls. I says, "Oh, yeah, what? Tell me about those." She says, "Well, we went up to Birdseye up the canyon, and we had this guy that was having a heart attack and fell off of a ladder, and so he broke his arm and his hip, but we had to treat him like a heart attack." It's like, yeah, that's what it's all about. It's a lot of these traumatic injuries may be caused by underlying medical conditions. Happens all the time. So be aware and have an index of suspicion as you consider the trauma patient, that there might be these underlying causes. The hypoglycemic patient who gets in a car crash or passes out and falls. Those sorts of things happen all the time. Definition: trauma is injury to the body resulting from some external force. We'll talk about kinetic energy here a bit. But traumatic injuries affect people of all ages and groups, and so we don't get to think about, oh, well, this is a geriatric condition or this is a pediatric condition. These are across the board. Everybody gets involved. So be prepared to respond to and properly assess and manage these types of trauma patients.
Oh my God, look what you just did to my car. Hello, lady, car stopped ahead of you. Maybe if you'd stop cramming your face full of ice cream, you'd notice these things.
Is everybody here okay?
Yeah, I just got rear-ended, that's all.
Does anybody need an ambulance?
Well, I got a little whiplash, but I think I'm okay.
All right, we need to keep traffic flowing here, so go ahead and get back in your cars, and we'll get ready to move them to the shoulder.
What?
Holy crap, Johnson, come here. Did you see this mechanism of injury? Why isn't she C-spined yet? I want those batteries cut, and I want C-spines here now. Much better. Alright, McMahon, I know this seems kind of silly, but why don't you go ahead and cut open that other car and cut that battery too, just in case.
Oh, ma'am, if you go and lay down for me, I'm gonna put this brace down on your neck.
Look, my neck's just a little sore. I don't need any of that.
Ma'am, with all due respect, just look at that mechanism of injury.
Yeah, my car got hit.
Do you realize that tomorrow morning you could wake up and be a paraplegic? Is that what you want? Ma'am, come here. Does this hurt?
Ow, yes, that hurt. Ah!
Because that shouldn't hurt, ma'am. That should not hurt. Something could be wrong with your neck, okay? So you should probably let us take you to the hospital.
Okay, what do we got here? Holy, look at that mechanism of injury. Why isn't she C-spined yet?
Well, she just doesn't think that anything's wrong with her.
Well, did you even try the poke the spine test?
Twice. I guess she just doesn't understand the scientificness of that test.
Look, guys, I really feel like I'm okay. You're starting to scare me.
Ma'am, you should be scared. You see this? I didn't spend 22 weeks at EMT school for nothing.
Alright, go ahead and lay back and relax, and we'll get you wheeled on over to the ambulance, okay?
I think this is a little too serious to be hanging out in traffic for.
Yep, those rubberneckers sure make a mess of things.
Dispatch 20 copies. Air ambulance landing on the freeway, and all traffic is already stopped.
MRE Air 1 on approach. Whoa, look at that mechanism of injury. I hope they C-spined her.
A helicopter, really? How much is this gonna cost?
Let me ask you this. Wouldn't you say that your life is worth a mere $17,000?
17,000?
Shh. No thanks is necessary, ma'am. Just doing my job. Well, at least I won't have to drive very far.
That was kind of a cute little mechanism of injury thing, but let's talk a little bit about this mechanism of injury and the law of inertia. Sir Isaac Newton made the discovery, we'll call it, that a body in motion will remain in motion unless acted upon by an outside force, and a body at rest will remain at rest unless acted upon by an outside force. So basically nature is lazy. Once you're moving, you're moving. If you're stopped, you're stopped. And so what happens though in these laws of inertia is that those outside forces cause a lot of injury. Okay, so you've all heard of Sir Isaac Newton. He's credited for discovering gravity. I'm sure people have been following a long time before he ever discovered it and been hit on the head by things. But nonetheless, what he did recognize was kinetics, the laws of physics. And he is credited for being the father of physics because he did recognize how objects in motion are affected by outside forces and how energy distributes when objects collide. He was quite an intelligent guy for a guy in the 15th century. So in his laws of kinetics, first of all, he recognized that energy can neither be created nor destroyed. It can only be changed from one form to another. We see that in solar panels, how light energy is changed to electricity, and we can see how the wind energy can be turned to electricity, and then how that electricity can be turned into heat. So it's not destroyed, it just changes and can be dissipated, but that heat still has the potential for energy. And that is what kinetics is all about, the functions of mass and weight and velocity. So his second law of motion was that force equals the mass times the acceleration or deceleration, and that has to do with vehicles can be the mass, or the person inside the vehicle can be the mass. So there's classifications of trauma. Blunt trauma can be either direct or indirect. And then there's the penetrating traumas, stabs and bullet wounds. As an object passes through tissue, energy is dispersed into the surrounding tissues, creating a temporary cavity or additional internal injuries. So what we see is as a projectile, particularly a bullet, passes through the body, actually as it passes through the air, it causes a disturbance in the air, but we have the laws of fluid that say that as it passes through the body, there's a shock wave, if you will, that disturbs the tissues, since most of the body is fluid, but because it's not totally fluid, it causes disturbance, which can cause severe bruising and injury rather than just in the projectile path. We call that cavitation. Attempts to determine the caliber of the weapon can be important, because that is the permanent cavity. It also its velocity helps us with the amount of destructive force from that projectile. Distance between the weapon, then where it was fired, and identified both the entrance and exit wounds. That happens too often that the EMS personnel will bring the patient into the hospital with a nice bandage on the entrance wound and not have noticed that there's a big exit wound on their back. So be aware that it doesn't always exit. A lot of times the bullet tumbles and fragments, but there can be quite a substantial exit wound if we're not paying attention. Stabbing wound, we don't have the velocity, but we have the potential for, I want to just say, wiggling the handle, and we have this cone of energy. We have to recognize that as the knife goes in, it may not go straight in, that it may be moved around. In fact, skilled persons with knives have learned how to do that, stir things up once the knife is in there. So recognizing not only where, also you know enough about your anatomy by now to know that a knife wound could cause severe injuries to organs that bleed profusely and cause internal and external bleeding. So be aware of that. Safety. You must not approach a scene unless it is safe to do so. What do you think? yeah, scary scene. So just be aware of scene safety. It can be traffic, it can be down power lines, it can be chemicals, it can be a dog. So be aware of scene safety. So let's talk about scene size up, the assessment of the trauma patient. This is your skill sheet, so know this, that first of all, scene size up includes standard precautions, BSI, PPE, however you want to word it, but personal protective equipment is important, and then ensure scene safety. Now, it's, again, difficult to ensure scene safety, but you can certainly be aware of the risks involved in the scene, and then identifying the number and location of the injured. This can be a problem when you do have a multiple victim event. People can be strewn if they were unrestrained in their vehicles. Bus crash is a perfect example of that, where the people don't wear seat belts and the buses roll and crash and leave people strewn across the road. Assess for mechanism of injury, recognizing that, yeah, remember it's NOI, MOI, so as we talked about, there can be a nature of illness associated with this mechanism of injury as well, so be aware of that, and then consider the need for additional resources. Do you have one patient who fell on a skateboard and broke his wrist, or do you have a car crash with a victim in each vehicle, or 2 or 3 victims in the vehicles that have fairly severe injuries? You need more help. And if there are hazards at the scene, don't approach. Stay back and contact appropriate resources to control that. So let's talk about the mechanism of injury, or the forces of energy that cause the injury. It's important to identify these forces, and each mechanism of injury has its predictable pattern or potential. Obviously, you can think of the fall victim. You know that they came from a distance and had a sudden deceleration into the ground. Especially, you can look at the ground that they landed on. Did they land on concrete? Did they land on a curb? All of those kind of things. This allows you to list some potential injuries based solely on that mechanism of injury. So we have a vehicle colliding with a tree, and that causes a sudden deceleration, and things happen to vehicles when that happens, and also persons in the vehicle. For example, then the body collides with the vehicle, the steering wheel. Fortunately, and they get a bad rap, but airbags do save lives, so do seatbelts save lives. Wear seatbelts. Be aware of the value of those airbags, but the body hits the steering wheel, causing broken ribs. So there are these 3 collisions. You've got the vehicle hitting the tree, the person's body hitting the vehicle, and then internal organs hitting walls of the body. So that's what we're seeing here, is those organs. Been on calls where the sudden deceleration actually tore the heart from its greater vessels. That's pretty much dead. Pretty hard to fix that without having a surgeon right there on the scene to crack the chest and clamp it off the arteries. And yeah, it's not a good outcome usually. So assess the patient. Collisions with the internal injuries, there's bruising, there's lacerations, there's tearing, can lead to massive internal bleeding that's not visible, as well as the external bleeding. Rely on your assessment and mechanism of injury to indicate potential bleeding, and then look for your skin color, diaphoresis, and your abnormal vital signs. So let's talk about the different ways in which these collisions happen and the forces that are related to that. So the frontal impact, the vehicle collides with another object, causing damage to the front end of the vehicle, which also causes rapid deceleration of the body inside that vehicle. This picture puts into my mind a great story on mechanism of injury. First of all, it shows that with the airbag and how a child in the front seat can collide with the airbag improperly. An adult, that airbag would hit him in the chest, but in this case the child is getting trauma to their head and neck as a result of it. But the picture on the right is the one that I want to talk about. We had a vehicle crash, sudden deceleration. This was when I was on the helicopter, and we were called in because the father had bilateral femur fractures, and so they wanted us to fly him to St. George for immediate treatment. But there was a child, a 5-year-old child in the car, and he was in the center. These were bench seats, so he was in the center seat in a seat belt. And I went and looked at him, and he had been scalped. His had a big flap of skin on the top of his head that had been scalped. And I was impressed with the EMTs not being overly concerned about this gross injury of scalp, big flap of hairy skin from his forehead. But I went over and looked at the car and could see that he had been scalped by the radio knobs on the dashboard. And I started looking at the scene, and this picture is a really good picture of showing how he folded in half like that and hit his head on the dashboard. And for him to do that, it would have caused, that seatbelt must have dug deep into his belly. And so I recognized that this kid had some significant internal injuries that were not being detected at the time because he wasn't showing yet the signs of internal injuries of his stomach. But I nonetheless said, no, we're taking the child. Dad can go up to Panguitch, to the hospital in Panguitch. They can give him blood product and get a fixed wing aircraft and fly him up to Salt Lake. But this kid needs surgery right away. And so we loaded him up in the helicopter and flew him to St. George. And before we left the hospital in St. George, he was already in surgery with severe abdominal injuries and severe bleeding. By the time we got him there, he was had a distended abdomen and was very shocky, and so we did do the right thing, and it was all just based on mechanism of injury rather than signs and symptoms. The kid, they used to every New Year's announce all of the fatalities from traffic accidents in Utah for the year. And that number was always mind-boggling and always growing. It was, 300, 320, 380, 400, 450 people died. And those numbers have gone down significantly in spite of the fact that we have far more traffic and far more people in Utah than we had then. But it's innovations like seat belts and airbags and freeways that we don't have people crashing head-on into each other at high speeds like we did then. So, but recognize that seat belts do save lives. Wear your seat belts. I've heard it said not a dozen, 100 times, but a dozen times, how this person would have been better off if they hadn't been wearing their seatbelt, or how this person's not wearing a seatbelt would have been dead if they'd have wore a seatbelt. Those are just so much bogus. Seatbelts save lives. The statistics prove it over and over again. So you guys, wear your seatbelts, and because you'll see these frontal impacts, how the vehicle crashes into something and then we crash into the vehicle. And if that thing that we crash into is the restraint belts, and therefore our deceleration isn't as intense, and we also have the airbag to soften that deceleration, we can see some real better outcomes from these crashes. So let's talk about, as we look at our mechanism of injury, these 5 categories. First of all, we had the frontal impact, rear-ended, lateral, rotational, and then the rollover. So let's look about each. First of all, when we have that front end crash, we can either go up and over if we're not wearing our seat belt, into the windshield, into the steering wheel. Seen that many times where they've put a faceplant into the windshield, and oftentimes even gone through the windshield. We had a gal down in Lake Powell. They were on the Bird Trail. She was actually in the back seat of the four-wheel drive vehicle, and the driver went off the road. He was cruising down this dirt road and hit the side of the hill straight on, and she flew from the back seat into and through the windshield and slashed her carotid artery on the glass in the windshield. We worked her all the way to the hospital, but it was a futile effort. We had IVs going, and she was bleeding out pink Kool-Aid by the time we got her to the hospital, because we couldn't control the bleed, and she would be doing CPR in the helicopter, but it was all for naught, if you will. Also, we can see the down and under pathway, where the person, this is our dad that broke his bilateral femur fractures. I had a bystander incident where I was driving through Myrtle Beach, South Carolina. It was like 2 o'clock in the morning, and came across the accident where a guy leaving the bar had gone down a dead-end street and crashed into a palm tree, and he was stuffed underneath the dashboard with his legs buckled up underneath there, and him trapped. And so ended up having to call fire and EMS and have them come and extricate him. We'll talk about vehicle extrication in another chapter. So as we run into these situations, look at the damage to the vehicle, because that can give you that potential for injuries, the mechanism of injury, by the way the vehicle looks, how they were impacted, and what happened to the people inside the vehicle. As we look at our vehicles and that mechanism of injury, we can see, like in these frontal impacts, if there's more than 18 inches of intrusion into the front end of the car, meaning that, and this is, cars are made to crumple now, and so we can see significant front end damage to a vehicle and have the passengers okay, especially with the airbags and seat belts. But be aware that if there's that much damage to the front end of the car, then there's a good potential for injury. Obviously, if they've shattered the windshield by people's heads, that's a really good indication of potential for head and cervical injuries. Bending of the steering wheel, I have seen where the steering wheel's all but folded like a taco down against the steering column because they were holding it so tight prior to impact. And then damage to the dashboard by heads. My kid did leave some hair on the knobs of that radio, so I knew that's how he had scalped himself. So these front impacts can cause severe injuries to the chest. We had a beautiful, I just got to say this, beautiful gal on a motorcycle who was headed up I-80 up towards the canyon, Parley's Canyon, and a car changed lanes into her, which caused her to lose control of the motorcycle, go across the medium strip, and head on into a little Honda. And then she was ejected from the motorcycle. And in fact, we brought in the helicopter and landed the helicopter between her motorcycle in the car and her body. We transported her to University Hospital, and she did not survive. But the sadder part of the story is that we were so concerned about this gal on the motorcycle, and it turned out that I'm going to give Gold Cross total credit for this one, because the driver of the other vehicle was a lady who, it was a head-on crash, but it was just a motorcycle, so and she seemed to be fine initially. But when Gold Cross started working her, she started getting very shocky, and they recognized some real severe trauma related to her, and it turned out that she had actually torn her aorta as the sudden deceleration of hitting this motorcycle and her hitting the steering wheel of the car had actually tore a greater vessel on the top of her heart, and she was bleeding severely internally. But they were able to recognize it, transported her to St. Mark's, which was a closer facility, and they got her into surgery and did save her life, in spite of the fact that she did have a torn aorta. But I'll give them full credit. While we were working this obviously impossible trauma victim, they took care of the one that was survivable. So recognize that, yeah, these injuries do happen in these frontal impacts. Liver spleens, sudden deflation of the lungs can cause compression that can cause pulmonary emboli, pulmonary also, we have in these head-on crashes, we can get these head injuries that range from lacerations to skull fractures and neck injuries as well. We get the Contrecoup effect, where the brain sloshes inside the skull, and so it will fly forward with the initial deceleration, and then opposite reaction causes the brain to slide back and bash into the back of the skull, and we get that contra coup type injuries. Okay, let's talk about rear impact. Again, one of the greatest things that we have in our vehicles now for rear impact is headrests, so that we don't get that hyper extension of our neck when we're hit from behind. However, seats fail in these kind of situations, and we can get this sudden acceleration from behind, which can cause so you can see we get this forward to backward motion. We first of all get hit from behind, which slams us against the seat, but then we have that equal and opposite reaction of then being sprung back forward and into the dashboard, steering wheel and stuff. Notice this guy is not wearing a seat belt. Wear a seat belt, and a lot of these injuries don't happen. If he'd had a lap belt, he'd have been much better off, as well as the shoulder strap. Okay, rear impacts, the vehicle is struck from behind, sending the vehicle forward, so we get a rapid acceleration of the vehicle, and then we get the whiplash effect from the hyperextension of the neck. Okay, side impacts. This is the lateral impact, and this is where, to me, that 18 inches or 12 inches intrusion into the vehicle becomes really more significant. As if it's from the side, then obviously the person inside has received severe impact from the crash. So we can see that you must consider this potential from the side injuries, the intrusion of the vehicle, as well as the rapid acceleration of the body into the energy coming from the side. Rotation is the spinning action of the car. It can cause, without seatbelts, it can cause ejection from the vehicle, which is never a good thing, and so we can get this spinning effect that has its twisting forces in the body to the body as well. Then we got the rollover, tumbling. Again, you see all the time people wearing seat belts who tumble and they climb out of the vehicle slightly bruised and banged up, but survived. And then we have the person who wasn't wearing a seat belt who tumbles around in the car and is ejected from the car, and then the car rolls over on them, and all of those types of injuries are associated with. So this is the tumble. Again, he's not in the car or not in a seatbelt, so he's not part of the car. He's being beat up by the vehicle. And so I keep telling you to wear your seatbelt because you can see the significance of not wearing a seatbelt, but recognize that people don't wear seatbelts like they should, and so we see these kinds of injuries. So that is one of the first things you're looking for is, were they wearing a seatbelt? A lot of times they will be out of the vehicle by the time you get there, and they will lie to you and tell you that they were wearing a seatbelt because they know that they could get a ticket for not wearing a seatbelt. So know that be suspicious of those injuries. Because we know what to expect, but it does tend that adults who are going to be hit by a car and see it coming will tend to turn away from it and probably take the brunt of it, first of all, in their hip. And whereas children tend to panic and freeze and face directly towards the vehicle that's coming at them. And I mean, it's just kind of a strange phenomena. But as a child is hit by a car, you just got to recognize that if I'm hit by a car, first of all, I'm likely to take it at the hips and knees, thigh area, because I'm tall enough that that's what's going to happen, and I'm going to go up and over the car. Whereas the child is short, and so therefore going to take the full brunt of it, and then be slammed down in front of the vehicle, and that's how they often get ran over, because the vehicle doesn't stop in time, and the child ends up under the vehicle. So I recognize the potential of the infant and children, well, not infants, infants would hopefully be in their parents' arms, but auto pedestrian accidents are never a good thing. So as we look at our auto pedestrian, recognize that speed is significant. Anything greater than 20 miles an hour can cause severe injuries. What part of the body was struck? We talked a little bit about upper body, lower body, distance the patient was thrown following the impact, can give you a hint as to how much injury they've had, and then the type and surface that the patient landed on. Did they get knocked into the side of the road where the weeds and stuff are a little softer landing, or did they end up on the asphalt? Motorcycles. I've been a rider for, well, I got my motorcycle license when I got my driver's license, and I've maintained it ever since. I've owned motorcycles. I don't ride motorcycles much anymore. My brother was, well, he was comatose for 6 months. He missed out on almost a full year of his life because of a motorcycle crash. And he's really suffering from the effects of that crash now in his older years. So yeah, motorcycle crashes, motorcycle riders seldom win those battles. Been on lots of crashes with victims, and they seldom fare well. We've got your lateral impact. People don't see motorcycles, and so we see them turning in front of the motorcycle and the motorcycle striking the vehicle. My same brother, at teenage years, he borrowed a kid's motorcycle, took for a ride, and I was upset because he didn't take me with him. But he took my buddy with him, and they ended up, a lady turning in front of them and them hitting the side of her vehicle, and both of them flying over the vehicle. And no severe injury except for the motorcycle was destroyed. But yeah, we can see that riders separated from the motorcycle is not a good thing, because now they're totally exposed. Have a friend who was very much involved in legislative issues and has fought the motorcycle helmet law in Utah every time it comes up. And he was killed in a motorcycle crash in Montana because he didn't wear a helmet. That was his results, and yet we still do not have motorcycle helmet laws in Utah, and I believe we should. Okay, let's talk about falls. The height of the fall is very important. body parts landing and hitting surfaces. I've had as simple as a two-story fall out of a window onto a concrete abutment, though was deadly for a 5-year-old child. So the surface they fall onto was significant. I've also had a guy fall out of a 4-story building, but he landed on a grassy hillside and had some significant injuries, but survived them. So it depends on the surface that they land on, and we got our direct injury is when they hit the ground, and then we got the indirect injury as the body stopped inside the body. The organs get injured as they hit the ground from inside the body. This is just showing how landing on our feet does transfer the energy, but it can transfer it all the way up into the back and cause compression injuries to the spine, as well as fractures to the legs, and even can cause cervical injuries from this kind of a landing. You see this in the parachute guys quite often if they don't land just right. We start looking at our assessment. We have to think about blast injuries. We know that they can happen in fires, in natural gas explosions. We've had firework injuries from that, and we're starting to see IED explosions, unfortunately, in our midst. So first of all, we have to ensure our own safety, recognize that a lot of times in terrorist situations there is a second bomb aimed at us. And then there are the 5 phases of injury. I think these are really kind of clever. There's the blast injury, the secondary blast injury, the tertiary blast injury, the quaternary blast injury, and the quaternary, which is Latin for 3, 4, and 5. It does make sense if you consider the primary blast injuries are a result from the pressure wave from the explosion, directly related to the force of the explosion. And then we have the secondary blast injuries, which is the debris thrown from the explosion as a result of that pressure wave, and that can be either shrapnel kind of stuff, or it can just be the stuff that is blown up out of the hole even. We have our tertiary blast injuries, which is the pressure wave, the debris that the patient runs into, or the surface that they crash into. And then we have the quaternary, which is the environmental conditions, the heat wave and the explosive gases that are involved to create the environment of injury. And then we have the quaternary, and this is the illnesses following the blast, such things as infections, bioterrorism, dispersals of their pathogens. And then lastly, we do have our post-traumatic stress disorder issues that come from these blasts. In a nutshell, you've got your primary blast, which throws the person away from the by pressure wave. You've got your secondary missiles and projectiles that can cause injury to the patient. You have your tertiary, which is when they impact a surface, maybe another wall, or causing injuries. Then you got your quaternary, that is the burning gases and heat and smoke, and possibly crush from collapsing buildings and that sort of stuff. And then, of course, we talked about the latent diseases that can come from this and the psychological disorders. So it doesn't matter what the mechanism of injury is directly, but maintain a high index of suspicion if there is a significant mechanism of injury, and consider transporting the patient to the appropriate facility with surgical service. For the non-significant mechanism of injury, remember that even though these may be less severe injuries, You do also have a requirement for EMS care, so your role can be assisting the patient, making sure they're assessed properly and that you're not missing any injuries, and then treat and package the patient, and then provide transport to the appropriate facility. Your primary assessment, identify the immediate life threats and treat them, use a systematic approach, perform a head-to-toe exam. Trauma patients have often gruesome injuries that can be distracting, so avoid those distracting injuries causing you to not perform a good systematic assessment. Manually stabilization of the head and neck can be important, especially if there's forces that have been applied to the head, neck, and back, and that would be determined from your determining mechanism of injury. Neurological deficit of extremities are present, so therefore package them appropriately with C-spine precautions. Patients with altered mental status, because we don't know what their injuries might be, we will go ahead and treat all of them as though they were did have possible cervical spine or back injuries. And then place hands on both sides of the head and hold them in neutral alignment. If their head is out of alignment initially, it is okay to gently, with traction, put it in that proper alignment. So far as airway is concerned, in your primary assessment, if there's blood or vomitus or anything in the airway, you must remove that, and then determine if the airway is patent. You need to look, listen, and feel for breathing. Abnormal respiratory sounds should be such as gurgling or snoring or stridor are indications of a partially obstructed airway. So be aware of what you're listening to. Patient is unconscious or with decreased level of response. Again, you still have to look, listen, and feel for breathing. You have to use a moderate jaw thrust or use the head tilt chin lift. Also, if you're going to have to use a jaw thrust, I would consider using an oral or nasopharyngeal adjunct, simply because it's too difficult to maintain that head tilt chin lift throughout your assessment. Primary assessment in breathing. If breathing is adequate, you may need to apply oxygen if the SpO2 is less than 94%. And if the breathing is not adequate, you may consider using a bag valve mask to ventilate the patient using high flow oxygen. If the lung sounds are diminished or absent on one side of the chest, possibly a pneumo or hemothorax may be present. All the more reason to add diesel to the situation. Primary assessment, so far as circulation, check for a pulse, skin condition, and do your blood sweep looking for major bleeding, and then assess the pulse for rate, rhythm, and quality. You're not going to count the rate at this time. You're just going to notice that it's fast and that it is steady or slow and steady or slow and erratic, and that it's thready or a weak pulse or a bounding pulse. And then you can do your skin cool, clammy, diaphoretic, looking for those signs of shock in the skin, and then perform that blood sweep again to control life-threatening bleeding immediately while you're in your circulation mode. Looking for your disabilities, patient's level of responsiveness. You can use your AVPU mnemonic, alert, responds to verbal, responds to painful stimuli, or is unresponsive. You can use your Glasgow Coma score to determine their level of consciousness and possible outcomes. As we use our Glasgow Coma score, it's important to remember that we're looking for the best. So, for example, if the person has their eyes closed when you approach them, you call them, talk to them, they open their eyes, then they maintain eye opening, that is a 4, not a 3. So just kind of remember that we're looking for our best. Let's look at the revised trauma score. After we've got the Glasgow Coma score figured out, then we're ready to start our Glasgow Coma score, or our revised trauma scale, we'll put it that way. So we've got our Glasgow Coma score, and we recognize that we can break that down into less than 13 would be a minimal concern, and 9 to 12 would be a moderate, and then less than 8 would be a severe concern. So we can add that to the respiratory rate and systolic blood pressure, and we can come up with a specific score for our revised trauma score. So for example, if we have a Glasgow Coma score of greater than 13 or greater, and we have a blood pressure of 90 or above, or our respiratory rate is between 10 and 29, they're probably okay. Pediatrics, we might consider greater than 20 or requiring ventilatory support would be a concern there. When we're doing our patient assessment, we do need to expose the critical trauma patient to prepare for rapid trauma exam. You can't see it, you can't treat it. So protect the patient's modesty, however, be professional about it, but do a good thorough exam. We like to call that trauma naked. That doesn't mean naked, that means trauma naked, maintaining the patient's dignity, but being sure we've examined the patient. So our secondary assessment, we have our rapid trauma exam for the critical patient and those with significant mechanism injuries. We do our baseline vital signs so that we can initiate our trending of vital signs. Medical history as best we can obtain, either from the patient or from bystanders, and then either focused or head-to-toe exam depending on the patient's mechanism of injury, complaints, and overall condition. Focused exam means they fell and broke their arm, that's the OWI, so you focus on that, doing just a brief overall assessment. And then a rapid trauma exam is a quick visualization, palpation of vital areas of the body to identify life-threatening injuries. And then, of course, what does the DCAP BTLS stand for? Hopefully you've got that one down by now. And then we have our rapid trauma assessment, your head to toe, we call it. Head, you're looking for bruising, spinal fluids, cerebral spinal fluids coming from the condition of the eyes. Again, rechecking the airway while you're looking for broken teeth and broken noses and bleeding. Then we evaluate the neck. We're looking for our tracheal deviation and jugular vein distension. We're also looking to and feeling for step-offs and tenderness in the neck and the cervical spine. We check the chest. We palpate. We're looking for bilateral chest rise and fall, and we are listening for the breath sounds. So we're auscultating the chest as well. And then the abdomen, we are going to examine all 4 quadrants. I often see candidates or EMT students who check 4 quadrants all above the belly button. The belly button is the center, and the 4 quadrants are from there, so it is above, just under the right rib, just under the left rib, below the right belly button, just above the pelvic bones on both sides as your 4 quadrants. Your extremities, remember you're checking for pulse, motor, and sensory, as well as crepitus and tenderness in the extremities. And then you're also going to check the posterior. Now, back to the pelvis, remember that genitalia is part of that. You're checking for spring in the pelvis. Gently, if you elicit any pain, you quit. And so we do want to make sure we've checked our pelvis as well as all of our other areas. And then the posterior, we may need to log roll the patient, but it is possible to, while the patient is in a supine position, to reach under and palpate along the edge of the spinal column without causing any unnecessary movement. So consider that rather than having to roll them up on their side to make that assessment. And then, of course, we're always examining for blood and fluids from the body. We have our baseline vital signs, the respiratory rate and quality. Make sure it's not just how fast they're breathing, but how deep or shallow they're breathing. The pulse rate and its quality, is it shallow, weak, irregular, and then blood pressure. And then we've got our subsequent vital signs that we can use to compare to our baseline vital signs that allows us to identify the trending. And then obtain your patient history. Use the sample mnemonic to help you obtain that. Also, you may even consider the OPQRST as well. And of course, we're also using our DCAT BTLS. So understand what those mnemonics are all about. Critical trauma patients, Glasgow Coma score of less than 14, systolic blood pressure of less than 90, and respiratory rate of either below 12 or above 29, and then infants above 20 or needing assistance. Our goal is to treat and package and transport the patient. So let's go over our head to toe one more time, since you don't get an opportunity to actually practice this in front of us. We're going to show you pictures to give you an idea. So first of all, head to toe, you start at the head, you feel the scalp through the hair. Now notice this guy is already on the backboard in the ambulance. That's because he's a critical patient, needs to be transported. So we've done a quick initial assessment and determined immediate transport. So we've got him in the back of the ambulance. So now we're going to do our thorough head to toe. So we're going to check the top of his head, looking for abrasions, DCAT BTLS. Palpate his face, his forehead, his jaw. We're looking for fractures, DCAT. Look in his eyes, look in his pupils. Look in his mouth for broken teeth or fluids in the. Look in the nares. Look behind the ears and looking for battle signs and raccoon eyes. Now we're going to check for tracheal deviation and jugular vein distension. We're also going to, we've checked his cervical spine. We may even need to take his collar off to do a good inspection of the cervical spine while we maintain the head in alignment. Palpate the chest, we listen to the chest, we feel for crepitus of the ribs, and we're looking for bilateral chest expansion or paradoxical movement of the chest. Those are the kind of things we're looking for, and then we're also going to auscultate the chest and listen to breath sounds. We're going to get to this abdomen. We're going to, again, palpate all quadrants of the abdomen. We're going to observe the patient's face for grimacing. He may be unconscious, but responds to pain, and so we're going to be checking for that, recognizing that he may be ticklish, so we can make sure we've ruled that out as well. Again, remember our 4 quadrants. The belly button does divide those 4 quadrants. Checking above the belt line usually is not an appropriate abdominal value. Okay, now we're going to palpate both sides of the pelvis gently with both hands, pressing downward and outward gently. Observe signs of wetness that may be blood or urine. Also, we're going to check genitalia if we feel like there's a need for that. If we do elicit pain or crepitus, we discontinue and just chart that we do have an unstable pelvis. We're going to evaluate the legs, assessing again DCAT BTLS, and we're going to check distal pulses for sensation. We're going to pull and push against resistance. We're going to push with our feet, have them push down, pull back towards their head, so we recognize that there's good flexation and extension. And we're going to check pedal pulses, and we're going to check for sensation. We're going to palpate the arms, both arms, assessing again distal sensations. We're going to squeeze both arms and make sure that we have no crepitus or deformity in our extremities, upper. We'll have them squeeze our hand grip test, check for whether or not they've got sensation and whether or not they've got good radial pulses. Now it is possible, again, like I said, to reach underneath the back as best you can with your gloved hands and feel for soft spots in paradoxical motion, crepitus, subcutaneous emphysema, rib fractures. Those are the kind of things that we could be finding on the back. So for the critical patient, reassess vital signs and interventions every 5 minutes. If they're non-critical, we can reassess those interventions and vital signs every 15 minutes. Transporting patients to the most appropriate facility and using a proper mode of transportation, methods of ground transportation versus air transportation. If we do determine that we need air transportation, then we would go ahead and use it. We'll talk about transport operations in another lecture. But recognize that these are the conditions that we would consider it. The patient's condition, if he's critical of trauma and we're going to have a delayed time of arrival, if the aircraft can be there in less time. And remember, I worked on a helicopter for a lot of years, and I recognized that it's going to take time for the helicopter to arrive, and even when it's there, it's going to circle looking for a safe landing place before it lands. It's going to wait till the rotor stops spinning before they load the patient. So you're talking probably 10 minutes even after they're overhead. So recognize the time element as you consider it. Weather conditions, helicopters don't fly well in snowstorms. And then your ground transport time can be another consideration, and the location of potential landing hazards, such as trees, a lot of tree area, power lines, and those sort of things. And specialty care hospitals do provide specific transport service as well. So you may have a pediatric ambulance or something like that coming out of like primary children. Okay. Let's look at our quick summary. Seems that critical trauma can be very hectic. Remain focused on and organized, do a systematic assessment, treatment, and packaging. Make a good transport decision. Failure to manage emergency in an efficient manner can lead to increased in morbidity and death. And the goal is to minimize scene time by transporting the patient to the nearest appropriate medical facility. So now here we've got our whiteboard quiz. You'll have a sheet available to you with these questions, and you can go ahead and mark A, B, C, D on each one of them, and we'll see how we do. So the first one, you're injured. The injury that occurs to the part of the body as a result of an energy being transmitted through the body is called indirect, direct, significant mechanism of injury, or blunt trauma. Give you a minute to answer that. And if you did get A, you are correct. That's your KED, by the way. 2. An up and over path is one that could have occurred during which type of motor vehicle impact? A lateral impact, A, a rotational impact, B, a rear impact, C, or a frontal impact, D. Do you remember the up and over pathway? Up into the windshield, right? So that would be a frontal impact. Number 4, in which type of motor vehicle crash is the potential for ejection of the patient most likely? In a rollover, in a lateral impact, in a rotational impact, or a rear impact? Shouldn't take too long on this one. I would bet you've got it by now that it would be a rollover, especially if the patient is unrestrained. Number 4, unlikely low velocity trauma, high velocity penetrating trauma. Let's try that again. Unlike low velocity trauma, high velocity penetrating trauma can cause significant internal injuries resulting from direct injury, indirect injury, blunt trauma, or compression trauma. So high velocity can cause indirect injury because of that wave effect of the high velocity projectile. The cavitation, we called it. Number 5, you should perform a head-to-toe exam after you have managed all life threats, immediately after the scene size-up, in conjunction with the primary assessment, or upon arrival at the emergency department. I hear you thinking a little bit. Obviously not D. In conjunction with your primary assessment? No, I think it would probably be A, after you have managed your life threats. Number 6, during which of the following components of assessment should you identify immediate life threats and treat them as they are identified? Is this in the scene size-up, in the primary assessment, in the secondary assessment, or in your mechanism of injury? Okay, you're right. It's the primary assessment. All right. 7. You arrive on the scene of a motor vehicle crash and note that there is approximately 18 inches of intrusion to the driver's side door of the car that was struck with a lateral impact. What type of injury would you suspect the driver to have sustained? Whiplash, critical injuries, fractured left arm, or significant left-sided injury? Okay, we're going to say critical injury. That is kind of the definition of why we would transport a patient. The mechanism of injury with an intrusion of 18 inches would automatically classify as a critical injury. Number 8, given this image, what type of injury would you suspect the victim to have sustained from this tertiary blast injury? A, whiplash, B, loss of hearing, C, back and neck injury, or D, shrapnel injury? I'm going to guess back and neck, because that's when he's going to hit that wall post or whatever that is into his back and neck. That's his tertiary. Okay, these are questions from your book as well, so these are the review questions. Kinetic energy is a calculation of weight and size, weight and speed, mass and weight, or speed and force. I'm going to guess C. Nope, I'm wrong. Weight, which is mass, and speed would be the correct answer. Mass and speed, or weight and speed would be right, but we'll go with that. Number 10, a 20-year-old man has major open facial injuries after the vehicle struck a tree head-on. Which of the following findings within the car would you most likely explain this injury pattern? Deployed airbag, bent steering wheel, non-intact windshield, or a crushed instrument panel? What do you think? Major facial injuries, probably not from an airbag. So it's probably a non-intact windshield, a broken windshield. Which of the following would most likely result from the third collision in the 3 collision effect that occurs during a high-speed frontal impact motor vehicle crash? So the third impact. Extensive damage to the automobile, flailed chest and lower extremity fractures, massive external trauma with bleeding, with severe bleeding, or the aortic rupture or compression injuries to the brain. Okay, the third impact is the aorta. The automobile crashing into this would be the first impact. The chest crashing into the steering wheel would be the second impact, and then the aorta tearing would be the third impact. A young male experienced severe blunt chest trauma when his passenger car struck another vehicle head-on. During your inspection of the interior of his vehicle, you would most likely find deployed airbag, steering wheel deformity, starring of the windshield, or a crushed instrument panel. Give you a minute. Okay, we're going to suspect steering wheel deformity. The deployed airbag would cause abrasions and stuff, and so it wouldn't cause severe chest injury like the deformed steering wheel would indicate. Number 13, an unrestrained driver collides with a bridge pillar. Upon inspection of the interior of his vehicle, you note that the lower dashboard is crushed. During your assessment of the patient, you will most likely encounter trauma of the pelvis, blunt abdominal trauma, severe closed head injury, or penetrating thoracic trauma. Again, thinking lower dashboard would cause probably his knees to hit the dash and cause his sockets of his greater trochanter sockets to fracture and fracture his pelvis. Number 14, whiplash injuries are most common following which type of impact? A rear end, a rollover, a frontal, or a lateral impact? Okay, anybody that's watched any ambulance chasing lawyers would know that that's a rear end collision. Number 15, death from a rollover motor vehicle crash is most often secondary to crushing injuries, A, airbag-related trauma, B, multiple collisions to the interior of the car, C, or ejection of the patient from the motor vehicle. You decide. Okay, number D is most likely. C does have some potential. If they're not restrained, they're going to be rattling around inside the car, but the most likely cause of secondary injury is going to be them being ejected from the vehicle and possibly crushed by the vehicle as a result. Number 16, severe abrasion injuries can occur when a motorcycle rider has slowed after a collision by a road drag. Road drag is most often associated with which type of motorcycle impact? A head-on collision, an angular collision, an ejection, or a controlled crash? And I'm not sure what a controlled crash is. I understand you might be saying you can lay your motorcycle down, but that often ends up in the same kind of situation where it's an ejection. The rider is off of the vehicle and getting road rash all over the place. Okay, number 17, when assessing a stab wound, it is important for the EMT to remember that stabbing of an extremity are rarely associated with exit wounds. B, the majority of the internal trauma will be near the path of the knife. C, most stabbings are unintentional and cause less severe internal injuries. Or D, most internal damage may be present, more internal damage may be present than the external wound suggests. Try that once more, go through it. Okay, and the answer is D, more internal damage. Now, B does have some merit, but we should be suspicious and have our suspicions up that although the major injury may follow the path of the knife, it is very possible that the knife has been swished around in there. So let's remember that as a concern as well. Okay, number 18. A 40-year-old man was standing near a building when it exploded. He has multiple injuries, including a depressed skull fracture, severe burns, and an impaled object in his abdomen. His head injury was most likely caused by which type of blast injury? A primary blast injury, a secondary blast injury, a tertiary blast injury, or a quaternary blast injury. Likely caused by him hitting into something, the ground, or something that would have caused the skull fracture, so it's tertiary. When you strike objects, being thrown into objects in the ground and those sort of things is the tertiary.